So this afternoon's panel is on SARS-CoV-2 disinfection and PPE reuse. It's a pleasure to see a diverse roundtable with members from government, university, and industry. Similar to our last roundtable, I think each panelist will give a brief presentation, and then we will save the questions and the discussion until the end. So first up in this roundtable, it is my pleasure to introduce my remote NIH colleague from probably the most beautiful laboratory setting in the country, Lieutenant Commander Megan Brose. She is the Biosafety Manager and an ARO for the Integrated Research Facility at the NIH Rocky Mountain Laboratories in Hamilton, Montana. Megan has a BS in Clinical Laboratory Science and a certificate in Molecular Diagnostic Science from the University of North Carolina, Chapel Hill. She completed the National Biosafety and Biocontainment Training Program at NIH before joining the Biosafety team at RML in 2009. Megan is also a Lieutenant Commander with the Commissioned Corps of the United States Public Health Service. Thank you, Megan. And has deployed as the Biological Safety and Infection Control Officer for various public health emergencies across the country. And at this point, I'll have Megan share a little bit about their research at RML.
BSL-3, our PPE, consists of a front cover gown or Tyvek suit coverall, disposable shoe covers, 2 pairs of disposable gloves, an N95 respirator or a powered air purifying respirator, and eye protection. And then at BSL-4 is our standard positive pressure suit. And it is important, I think, to note that we try to do as many of the studies with SARS-CoV-2 in the BSL-4 as possible to conserve disposable PPE, especially in this time with shortages. So we have been lucky and fortunate enough to not have to reuse PPE at RML at this point. We did begin planning for a worldwide PPE shortage at the end of February and beginning of March. We learned that from the SARS-CoV-1 outbreak many years ago. So we evaluated our current inventory and the usage rates and also the deliveries we had for outstanding orders. And our goal, we decided, was to have a 6-month supply for all of these items. And we reevaluated the status every week in our incident management team, and we continue to do that weekly through that IMT meeting. And so we found that there are some items in high demand that we're having difficulty restocking, including any Tyvek material, either the front cover gowns or the coveralls. Medium-sized nitrile gloves are also difficult to come by, as well as the front cover isolation gowns that we wear in our standard ABSL-2 facilities. So we're looking through alternatives for these in case we aren't able to get a resupply when we need them. So I'd like to introduce or summarize some research by our very own Dr. Vincent Munster here in his Laboratory of Virus Ecology at RML. They, like many of our other colleagues, have realized that a lot of institutions are going to have to reuse PPE, especially N95 respirators, and would need to find suitable ways to decontaminate them. So they evaluated 4 different decon methods, including ethanol, dry heat, UV, and vaporized hydrogen peroxide. And they looked at 2 different things. They looked at the effectiveness of these decon methods against SARS-CoV-2 for inactivation within the N95 filter materials, and also the effect of the decon methods on the respirator function and performance by conducting fit testing. So for the first part, for inactivation efficacy, they inoculated N95 filter fabric with SARS-CoV-2 and then exposed them to these 4 decon methods at different conditions and compared the inactivation rate to that on stainless steel. So for ethanol, they used 70% ethanol with a 10-minute contact time, and both N95 and stainless steel materials were completely inactivated in 10 minutes. For dry heat, they used 70 degrees Celsius and used 10, 20, 30, and 60-minute exposure times. And for N95 filter material, it achieved inactivation within 30 minutes. And for stainless steel, it took the full 60 minutes to achieve inactivation. For UV, they tested 10, 30, and 60-minute exposure times. And it was sort of the opposite with UV. N95 material took 60 minutes to the full 60 minutes to completely inactivate, and stainless steel was the shortest to 10 minutes. As for VHP, they used 1,000 parts per million at 10 minutes contact time, and both N95 and stainless steel materials were completely inactivated in 10 minutes. As for the second portion of their study, they conducted the N95 fit testing after each round of an individual wearing the N95 for 2 hours, followed by that decontamination method. So that consisted of one round, and then they did that 3 times for 3 consecutive rounds to add not only to see what the effect of the decon method was, but also the wear and the added stress from the individuals wearing those. So after the first round of wear and decon, all 4 decon methods passed the fit test. And then after the second round, the ethanol quickly failed and was not effective after that, but all other methods were continued to pass. Then after the third round, the dry heat method also caused the N95s to fail, so only the UV and the VHP were able to pass after the third round. So they summarized that the VHP is the best combination of rapid inactivation of SARS-CoV-2 and maintaining or preserving the N95 respirator integrity. The UV inactivated SARS-CoV-2 more slowly, but it still did preserve that N95 respirator integrity. Dry heat does inactivate SARS-CoV-2 similarly to UV, but it only survives with the integrity for 2 rounds of decon and wear. And then, like we said, ethanol did reduce the respirator integrity rapidly, and it's not a recommended method for decon. They indicate that UV and dry heat does need sufficient time to ensure the reduction of the virus, and that will depend on the initial contamination that's present. And they do provide estimated decay rates and estimates of real-world contamination in their paper and their supplemental information, so that might be useful for you in your risk assessment. So you can definitely check that out if that can be of help. And finally, our BSL-3 and BSL-4 room decontamination procedures. For BSL-3, we use surface decontamination with disinfectant, and that currently for SARS-CoV-2 for us is 5% microchem, and they follow that with either 70% ethanol or a dilution of lab sand cleaner to remove the sticky residue that exists after the microchem. And then for BSL-4 labs, we use our standard formaldehyde gas decon procedure. And in the future, we're currently validating and testing the Steramist ionized hydrogen peroxide system. We were able to learn a lot from Miguel and UTMB, all the work that they have done. So we're following in their footsteps and testing the surface unit for BSL-3 applications, particularly for removal of equipment from the lab. And then we're testing the environmental unit for use in the BSL-4 in our room decons and hope to eventually move to testing. So this concludes my presentation.
Okay, thanks, Megan. So next up, our next 2 panelists are Dr. Miguel Grimaldo and Ms. Corey Intifero, who both hail from the University of Texas Medical Branch in Galveston, Texas. And there they are, sharing the same conference room. Dr. Grimaldo is an assistant professor for the Department of Pathology and Director of Institutional Biocontainment Resources at the University of Texas Medical Branch in Galveston. He obtained 2 Bachelor of Science degrees in the fields of agricultural engineering and agricultural economics from Texas A&M. And he also has his Master of Engineering and a doctorate in applied biochemistry. Dr. Grimaldo has more than 20 years of experience in high containment lab operations, and his current responsibilities include the review of all design, construction, commissioning, operation, and decontamination of the BSL-3, ABSL-3, and BSL-4 labs at UTMB. He is also a member of the IBC, and also noteworthy that before coming to UTMB in 2005, he worked for 13 years for the U.S. Department of Agriculture at the U.S. Embassy in Panama, where he was involved with USDA's foot and mouth disease prevention program, as well as the screwworm eradication program. Coming from USDA, I have an appreciation for that. Corey is a EHS consultant with the Biosafety Program at the University of Texas Medical Branch, and she is responsible for day-to-day management and oversight as an ARO of the UTMB Select Agent Program. Her primary expertise is in high and maximum containment facilities, and she has played an integral role in the COVID-19 response at UTMB, pertaining to N95 reprocessing, and continues to lead the efforts in the N95 recycling program. So I will let you 2 take it from here. Thank you.
Thank you. Can you hear us well?
I can hear you.
Okay. Thank you so much. Thank you for the invitation to allow us to present this afternoon some of the work that we've been doing, Corey, myself, and a group of others, in regards to the decontamination of N95 and validation of this decontamination process and the reprocessing of the N95 for our hospitals. So back in March 2020, right after the CDC symposium, this outbreak really started here in the U.S., we were anticipating that we were going to have a shortage of N95 for our hospital system. We knew that we had some supplies here on the research side, but we knew that we were going to run out, and we needed to find a way to decontaminate and be able to start reusing this N95 and other PPE as well. So we started having meetings with the infection controls in the hospital, and we to propose different ideas. One of the ideas as a group that we decided to do was to use autoclave decontamination instead of other methodologies that we have here available in UTMB, because it's more common to have autoclave in every hospital, clinic, and dental clinic as well, than you have, for example, have all these sophisticated decontamination equipment like vaporized hydrogen peroxide or chlorine dioxide gas or others like that. So we decided to go ahead and start doing autoclave first and see what we could find depending on the N95, and then use also hydrogen peroxide as well for material that could not tolerate high temperatures. So what we're going to present here, the portion that I'm going to present is part of the study that we published on the APSA journal this past, I don't know, June was it correct? Sometime May or June. So first, we for the decontamination test, we did both vapor phase hydrogen peroxide. We did up to 10 decontamination cycles. And for autoclave, we used 3 different temperature sets. 115 degrees C for 60 minutes, 121 for 30 minutes, and 130 for 2 minutes and 4 minutes. The reason why we did 115 and 130 was that we were calculating to see if we, with a lower temperature, achieving the same lethality, we could obtain, less damage to the material of the mask of the N95. And also at 130 degrees, even though it was a higher temperature, because the exposure time was going to be much shorter, also to see if we could get lethality and still, maintain the integrity of the material. For validation, we use, for the decontamination process, we use biological indicators. And the reason why we use biological indicators and not directly the pathogen is because we were very concerned about the other pathogens that our hospital staff encounters when they are dealing with patients, and some like TB, Clostridiums, other bacteria like that they are much harder to kill than what our envelope virus will be. That's why we decided that in order we needed to have biological indicators to guarantee that the contamination was successful. Also for validation, we did a fit test using a quantitative fit test. And in addition to that, we wanted to measure, or we wanted to see the degradation of the material and because of the decontamination process. And that's why we wanted to, we did some particle counting as well on the mask. We had a very stringent pass-fail criteria. For the autoclave, we have to have successful both biological indicators and chemical integrators to pass in order to say that the decontamination was successful. And for the vapor phase hydrogen peroxide, we also use Bacillus thermophilus, and they have to be 100% dead in order to say that it was a successful decon. For material integrity, we check on the shape of the respirator to see if the shape of the respirator will be modified. Also, we check the elastic bands, and also we did the particle counting for the material. And to see if they can be reused or not reused, we checked the integrity of the mask as a whole. Again, we checked the elastic band, make sure that you have a good fit test, and then we did the quantitative fit testing as required by OSHA. So any of those criteria that did not pass will definitely not be suitable. That mask or decontamination was not going to be suitable, or after the decontamination, the mask was not going to be suitable for use. These are some pictures or photographs of how we were processing the mask. Corey, I think, is going to talk more a little bit about why we're packing them in craft bags. But the idea was that once they come from the hospital, they will be enclosed in those bags, and that way we didn't have to touch the mask themselves and put them in the autoclave. The picture on the right is how we were testing, doing vapor phase hydrogen peroxide. And we did not just the mask, but we were also checking to see if we could decontaminate as well the Tyvek suits. We included the chemical integrators and the biological integrators, those test packs from 3M in the autoclave. And we also put them, when we were individually wrapping them, we put stereo gauge inside the mask and put them as well inside the autoclave. You see some of the results of the chemical integrators that we used, how we were making sure that we were always in the acceptable range. If it was not in the acceptable range, we said that the decontamination for that particular event, for that particular time, was not successful. Then something that we noticed was like for example, the 3M 1860 mask. These are folded masks. These are where the material is folded into shape. We noticed how the autoclave process was really damaging the shape of the mask, which is therefore it will not pass a fit test after that. So that was we said that definitely this type of mask could not be autoclaved. So for that one, we had to use hydrogen peroxide in vapor phase. Then for the you can also see some damages of heat, especially when we're doing the 130 degrees Celsius. You can see the foam, the neoprene seal that we have near in the nose, how those were getting damaged during the decontamination process. As a result, and this is one of the tables, some of the tables that were published in the article. So you can see that, for example, for 1860s, we did three masks for 60 minutes, 115 and 121 degrees for 60 and 30 minutes. Even though the stereo gauge passed and the test passed, they failed to pass the no-ash test or the fit test. Now, in particle counting, and I will talk a little more about that. Particle counting, the damage basically, you can see that they retain very well particle retention. For example, the 1860s, the molded mask, 130 degrees Celsius, they both passed the decontamination test, but they also failed the quantitative test. And then you see that you still have to see the longer the exposure time, 130, we saw a higher damage or less retention of particles. For the 115 degrees Celsius, for the 1805, I think, can you move that?
Stop.
I could see the slide. Sorry.
I don't know that.
Okay. So for the 1805, and why we selected this mask, this particular mask, the 1816, the 1805, and the 1870s and 1770 plus, because those are the most used masks here in our hospital and in our research departments. So for 115 degrees Celsius for the 1805, for 60 minutes, they both passed the decontamination, and they also passed the quantitative test. Now, and you will see later in some graph, I will show you how the degradation of the material. And then for the 1870 and 1870 plus, they both passed both the decontamination and the quantitative fit test. Let me show you some of the. Okay, you need to click the screen. No, move out there. Okay, now. So you can see, for example, some of the results of the particle counting for the 1805 at 150 degrees Celsius. As you could see, the mass, the control mass was pretty close to the 1, 2, or 3 cycles. The horizontal line that you see on top of 100%, that's a HEPA filter. You also see 1870 plus 150 degrees Celsius. You can see the effects on on the mass and deterioration, the more cycles you have. The 1805 at 121, you start seeing more deterioration of the material. Even though they were passing fit tests, you see more deterioration of the material the longer the more decontamination cycles that they were exposed to. And as well as the 1870 also have some deterioration, but if you compare the 1870s compared to the 1805, you're going to see that you have much better, the material holds the decontamination with autoclave much better. And I think that all of this information was published, as I said, in the APSA journal.
In Spanish.
And in Spanish?
Your word. You forgot one word.
Oh, sorry, I forgot that one. Now we have Cory that she will have to do this presentation in Spanish one time already, according for the reprocessing program.
Okay, so I was hoping to really cover for you. I think decontamination is really important, but I think one thing that we all know as biosafety professionals is we have a lot to offer during these epidemics and pandemics, and I really wanted to highlight how our biosafety office really became an integral part in this entire program, not just offering the validation, testing, and performing the decon. So I did want to just write one disclaimer here that, currently the FDA emergency use authorizations are granted only for use in healthcare settings by healthcare professionals, and so currently UTMB has not allowed us to decontaminate N95s for reuse in the research setting. So everything that we talk about today, we are only decontaminated currently for healthcare professionals in the healthcare setting. So I wanted to really give you guys an outline of this is a huge logistical challenge with anything that we do. And so I really would like to outline this for you guys just to show you, the process that it took and the amount of people really that we touched across UTMB here. So for those of you who may not be familiar with UTMB, we are a large healthcare system, but we also, of course, have academics, and infectious disease is really what we're known for here in research. So UTMB has 4 major hospital campuses, which spread out by over an hour each way. We also have 90 off-site clinics. So during COVID, the height of COVID, and as you know, Texas was behind a little bit the Northeast and the Northwest, so we were behind the curve a little bit when we really hit our height. But we had 4 major hospitals all operating, and then 15 of our 90 off-site clinics were designated as COVID patient care only. So these were the areas that we had set up these recycling programs. So the first thing that we had to do is, it sounds really great, just collect N95s and recycle them, but it's really not that easy. So we have, not only were we recycling, and we as in UTMB was recycling eyewear, goggles, and N95s. So while we were only decontaminating the N95 portion, we still had to come up with a system so that we could properly collect all the PPE that had to be recycled. And as you can imagine, people's stress and anxiety is already through the roof. And here we are showing up basically on grand rounds and teams with healthcare leadership, infection control, the physicians, and we really try to utilize the unit nurse supervisors to go to each unit, talk to the people, find a way that we thought this could work without disrupting too much. But this was a very new procedure for a lot of people. And so what we decided to do was set up what we call doffing stations, so that when people came out of the patient room, they could just walk across the hallway, and it was trash goes here, eyewear goes here, and N95s go over here. Now, when we first started recycling, we really focused on those 1860s just because they were the least amount of inventory we had in our warehouse. But over time, that grew to 4 to 5 to 6 different N95s, so we've had to adjust along the way. But it's not just about healthcare and safety, it's also about those support personnel, the people who are actually responsible for collecting those bags and moving them, and they are absolutely vital in this process. So what would happen is our environmental services would collect those bags that you see here at the doffing station, and they would transport them down to a medical waste storage room at each floor. Each floor and unit has one of these in the hospital. They would consolidate those bags into those large blue drums, and then the blue drums would be ready for pickup. Once the blue drums were ready, we would have our EPM staff or our hazardous waste contractor would then pick up the drums from each medical waste room, and then they would transport them to the G&L for us to begin the decontamination process. So once they are at the G&L, biosafety is responsible for coordinating and performing the decontamination cycles for each of the N95s. So I think we all know this, but biosafety is mostly about ingenuity. So during the height of the pandemic, there were not resources for us to go out and buy things and to be able to acquire and procure things. And so we, like everybody else, ran down to the warehouse, or actually our surplus, so things that were going to be thrown out, and we grabbed a bunch of racks, we rolled them over, and then we started to pillage everybody's office who was working from home while we were at the office. And so we found very quickly that paper clips and binder clips were really great. But lucky for us, 2 of us were really behind in packing our Christmas decorations. And so we were able to we found Christmas ornament hangers are actually by far the most superior thing to use and hang your N95s on. I'm sure there's much better use for these and other things, but what we had at the time, and I still prefer the ornament hangers even now with more supplies. So we would bring the barrels up to our BSL-3E. We decided that we would wear PPE from Papper's gowns, and we actually even wore facility-dedicated scrubs because at the time, we didn't really know what we were getting into. And so we wanted to make sure that we took extra precautions until we felt a little bit more comfortable with the process. And so I call us we're going to update our resumes to expert trash picking and sorting team because we became really good at picking through trash, essentially. While we had these great doffing stations, as you know, not only N95s end up in those waste barrels. As people are walking by, they just chuck things in them, not even thinking twice about these beautiful signs that we posted. And so we would have to open all the bags, and we would have to very carefully sort through each N95, and we got way more than N95s. We got surgical masks, we got gloves, we got IV bags, we got medications, we got gum, wrappers, food, all sorts of things. And so we would very carefully have to reach in, pick through the N95s, and then we would have to inspect each one of them to ensure that they were adequate for reprocessing, and then sort out all the ones that were for what we call disposal. So for those that were going to go through autoclave decontamination process, we singly pack one N95 in one of the following ways. So I actually prefer the Stericane bags. They hold up to autoclaving really well, and you can use them multiple times. Plus, you can see over here, you can stand them up in these nice metal bins. And so for me, I prefer this. This sounded like a really good idea, and we were like, we're going to train the staff, and they're going to bag all their N95s, and they're going to come to us just beautifully. They couldn't pack an N95 to honestly help us. So we actually ended up scrapping the bagging on the nursing side because it actually ended up being more work for us because we would have to open the bags, figure it out. The wrong N95 would be in the bag. There would be 3 N95s in the bag where they would wrap them up and tie them or something. And so actually trying to bag at the end, the user area, it didn't work well for us. So we scrapped that and just said, throw all the N95s in a trash bag and we'll worry about it on our end. So in each run, we would put the chemical indicators, and we wouldn't put one in every bag, but we would scatter them about within the autoclave runs, and then we would put a BI in with every load. So once we are done with the decontamination process, then we would move on to the post-decon packaging. So what we would do, just I'm sure similar to what everybody else has done as well, is we would mark on the mask a dot for every cycle that we would run. So while they're still hanging on the nice hooks, we would just turn them around and dot them, and then we would dot them, and then we all joked that we were really good at dotting and counting to 10. So we would dot, count to 10, dot, count to 10, and we would stack them all in packs of 10. So we decided that we were going to use safety deposit bags. Sounds kind of silly, but they worked really well for us. So the staff really appreciated having received reprocessed masks back in a sealed pouch where they knew somebody else hadn't tampered with it. So we used the deposit bags. We created a fact sheet off of really on the EUAs, what people were doing. We just made it our own. So we made a UTMV specific fact sheet that would be placed in each deposit bag. And then we made labels. We had started out labels with just one address label per N95, but it got to be too cumbersome, so we just made a giant label and all the N95 that we could just go through and check, and it became much easier. One thing that we did have a little bit of trouble with was some of the autoclaving, and especially the 1805. There's writing on the front of the 1805, and the autoclave would just actually almost erase and smudge all of that writing. And so post-autoclave, we actually were unable to read the size of the mask. So we couldn't tell if it was an 1805 or an 1805 small. So what we learned was we would label that autoclave bag with the size before we put it in the autoclave, just in case we couldn't read it on the way out. But then we learned to write on the elastic. This doesn't smudge here. So we would write small on the elastic band as well, so that when the end user got a mask back, they knew what size it was. The other reason why some of this was really important, and some of what Miguel had mentioned earlier, was the reason also why we wanted to do and demonstrate biological kill is we cannot guarantee that these masks get back to the same person. So we also wanted to ensure that we were killing any normal flora that healthcare workers may harbor, like staph or strep or something like that. So we wanted to ensure that we were not spreading germs healthcare worker to healthcare worker, since these masks were not going back to the same person. After we have everything packaged, we threw them in some bins, we would label them, and then they would go back down to the loading dock. So once they got back down to the loading dock, I'm sorry, I would also like to mention too, we did package these in the quantity that you would order them normally through your normal route in the warehouse. So if 1860s come in a pack of 20, we packed everything in packs of 20 for inventory management. We wanted to make sure when they did get back to the warehouse and people could reorder from our warehouse, that the supply chain didn't have to change the way they manage inventory. We created a pretty concise and hopefully easy clean, dirty drum staging system. So you've got people picking up clean drums and you have a separate group dropping off. And what we didn't want to happen is these things get crossed. And so we made signs, we did labeling, and we tried to be as clear and concise as possible. And then just trying to create labels for easy identification, as I mentioned before. Most importantly, I would say tracking our reprocessing efforts. I think everybody on here can probably appreciate the time and effort that we have dedicated to COVID-19 response is something that will probably go unrecognized as a whole. But what we did want to do is assist our healthcare leadership and supply chain with making the right decisions, or assisting them in making some decisions. And so I started a spreadsheet where we could track everything that we did, so that we knew on what day how many barrels showed up. We knew how many respirators we had received by respirator type that day for reprocessing, how many we had to dispose of because they were damaged or soiled, and then how many we actually were reprocessed. And then we would calculate for them the percent that we did have to dispose of, and then we would also track other things like makeup. So at UTMB, they decided that even if the mask was soiled with makeup, we were still going to reprocess it, even though it's like, but it didn't in fact, affect the integrity of a fit test. And because the 1860s were so precious and still are really, we did not want to be throwing away, and this is my last column here, especially for makeup over here. And this also helped us really aid in retraining as well. So we would track our time and effort. We track that disposal rate. We would consult with the supply chain very often and assist by directing and maybe prioritizing the recycling efforts based on which N95s we were receiving based on the inventory currently in the warehouse. And it would allow us to very quickly shift our efforts if we had to. It also assisted our occupational safety with figuring out through the fit testing program, oh man, we're really running low maybe on 1805s. We better make sure everybody who was only fit tested for an 1805 has been moved to a different N95 now, because we're getting low and there's not much left. So while the spreadsheet is a lot of effort, I think it has paid off pretty well for us. It also allowed us, with the inspection and really trash picking, real-time retraining of staff. And since we were labeling the drums, we knew where everything was coming from. And so we did find a lot of makeup. We found a lot of what we believe is improper doffing. Now, of course, people may say, well, how do you know they're improperly doffing? There's a point where straps would be torn off the mask. Or we would receive a mask that would be like folded in like quarters, and then the straps would be wrapped around. There's no way you can safely take off your mask and do that. So we knew there were some areas that needed maybe some extra training. We also saw surgical masks being worn over N95. Why did we know that? Because they were perfectly together in the trash, and it was one after another after another. While this was an accepted practice at many institutions, UTMB had not authorized that here, so we were able to report back to infection control to try to, move efforts. We also saw a lot of Band-Aids and tapes and things put over the soft foam of the nose cushion on the N95. And again, at UTMB, they had not authorized for those things to occur, and so we do know that they can affect the fit test. And so we were able to really take care of those very quickly. So lastly, and since, I guess, April, I think we started with our first decontamination for healthcare, and we also did the N95s for the Galveston County Health Department here as well. They were conducting all of the drive-through testing in our area. So as they would drop off tests or samples at UTMB for diagnostic testing, they would just drive by here, they would drop off the buckets to me, and then we would decon, reprocess, and give them back for them as well. So a little bit of, I guess, community outreach there. So in total, we are at about 15,000 N95s that we have reprocessed, and you can kind of just see overall, obviously the majority, over 14,000 were 1860s and 1860 smalls. The Prestige, I'm not sure if this is one that everybody's familiar with, but this is a Texas, there is a company in Texas who manufactures these now for us. We have decided at this time, as we know, no N95s were ever really manufactured to be reused, but we are finding a lot of damage with the Prestige N95s after one use. Just the integrity really is not there. So we have decided as an entity to halt any decontamination of Prestiges. They will be one-time use only and then be disposed of. And so currently we are doing, I would say 4. We were doing 5 plus the 1512s. But so really that's kind of where we are at this time. And we are kind of debating what we will continue. We still cannot get any 1860s, so we will continue the efforts for reprocessing the 1860s. But trying to get people to different types of N95s, like maybe the Halers or an 1804 or the 8210s. But those are decisions for healthcare to make, and then we will just assist as we can. So we've learned a lot of lessons and got really grossed out, but one of our favorite things was to call Miguel down to the window in the BSL-3 and see if we could surprise him and get him to take a picture of some of our prized possessions we found in the trash. And so, like I said, we found a lot of soiled masks. We did, at the end, have finally got people to stop wearing so much makeup, but in the beginning it was a lot of makeup, but I will say it has really toned down. We found a lot of hazards in the waste, and again, I don't think this was intentional, but one time we found like a giant thumbtack that just happened to be like pointing up, and we only found it because it was pointing up well, and it was like a 1-inch tack. And I think it just fell off of a board that was above one of the waste containers. So we went back around and made sure none of the waste containers were under, boards and things like that. What we did find out is these things mold very quickly if you do not get them and sort them and get them into a dry environment. From candy to gum to banana peels to coffee cups, it all equals mold. And you can see that very nice picture we got Miguel to take us at the bottom. This is just mold from a banana peel and a coffee cup in a bag that we found. So we did learn, once you get them, turn them around and at least get them sorted and dry until you can process them. So that's what we have for you today, and we'll be happy to answer any questions at the end.
Thank you, Miguel and Corey. That was amazing. Okay, so our final panelist in this roundtable is Ms. Morgan Holsey. And Morgan is the Director of Validation and Commissioning with Technical Safety Services, one of our symposium sponsors. She has a BS in bioengineering from the University of California, Berkeley, and she supports and directs TSS's documentation quality and report delivery teams, as well as the project management and special projects division. So I'm going to hand it off to Morgan.
Thank you. Hello, everyone. Thank you for inviting me to present today. I'm looking forward to talking with you all. Some of what I'm going to talk about is going to overlap a little bit of especially what Corey discussed. TSS has had an EUA provided for large-scale vaporized hydrogen peroxide disinfection of N95 respirators. So some of the same constraints in decision-making you'll see common among our process and again, what Corey shared. So TSS is a testing and certification organization. We provide decontamination services, large scale and small scale, in routine laboratories, academic, any situation where we can provide that service. When COVID-19 came into all of our lives, we looked at how can we help. This is something we do routinely. How can we apply it to PPE and provide a service for healthcare organizations who might not have the bandwidth or want to pursue doing it internally? So with locations all across the nation, we really felt like we had a really great footprint in order to provide that service. So some of the first things we started to ask ourselves are, how can we do this safely? How can we make this portable? How do we do this in a high volume? Because there are solutions that can do a low volume of PPE disinfection, but if we want to really make this a bang for our buck, let's go ahead and see if we can get a lot of respirators disinfected quickly. And what are the inherent aspects of an N95 that we have to consider for our disinfection process to be tailored to this application? We had never gone through disinfection of N95s before, although we've been using this disinfection process of ours for decades. So we wanted to make sure not only, were we applying our expertise for our process, but did we tailor it sufficiently for PPE? So we considered the dosage of VHP, the duration of the process, effect on fit, effect on efficiency. Is there any residue? And if there is, how do we consider that in our procedure? The logistics, if we're designing this process for one of our sites, that's much different than a portable solution to go to any healthcare facility across the nation. And how do we do this in a way that we give the most informed consent to the end users? This is also something that was really highlighted with the FDA and in our EUA process. So we wanted to make sure that we were holding up our end of the bargain for really representing what PPE reuse means in terms of after disinfection. We were able to successfully do this. Like I mentioned, we have an EUA for this process. We've been using this weekly at least one healthcare facility, and at this point have disinfected over 80,000 masks with very high success rate. We've only had to redo one cycle of masks related to some biological indicator results that we weren't happy with. So we've rerun one cycle out of that 80,000. And when I'm talking about a cycle, our disinfection process is a 35% hydrogen peroxide solution that's generated to at least 480 ppm or above. On average, our cycles are about 1,200 ppm for the duration on the average of our generation and our dwell period. And this is based on the information that was available at the time of other EUAs that had been delivered, FDA studies, and TSS's decades of disinfection. So some of this is, again, repeat. This number is a little bit outdated. We are at the 80,000 mark. And each of our runs is 4,000 to 5,000 masks. So our solution really did hit our goal of large volume. Process overview. So this really mirrors what Corey was talking about. So we partner with our healthcare clients who are looking for us to use our solution to help them disinfect their PPE. They'll label masks. We use a QR code tracking system. So we considered the marking of the masks and found that for the volume throughput, we really wanted to see if we could leverage a software solution. So we developed some tags that could go along the band of the mask, and they have a QR code. That QR code is then matched to a label number that's written on the mask so that we can track even if the code falls off or the label falls off the mask. And when you scan the code, the total count of disinfections, the date of disinfections, any comments about the disinfections will come up for that particular mask. Following use, we collect them. That's up to the healthcare facility to decide the best practice for them. They're released to TSS. We have a chain of custody to indicate what types of masks, the condition of the mask at release, any that we exclude from our disinfection, the disinfection, and then we confirm results with biological indicators. Those biological indicators are made for VHP and provide a 6-log reduction result. Then those masks, once we have the successful BI results, are released back to the healthcare facility. Every healthcare facility that we do partner with will develop a site-specific protocol for how we're going to interact. Again, much of this process is, there's partnership points between the release of the mask to TSS and the release back to the healthcare facility. So we'll generate a specific protocol to that facility. And then at the facility, we'll bring our portable disinfection enclosure. Like I said, it's large volume. It's built specifically for this process with custom racking along both sides of a 20-foot enclosure. It's fully supported with HVAC, fans, monitoring for real-time ppm, temperature, and humidity, so that we can have, deliver the enclosure to the site, do the disinfection, and only have to plug in the unit. The collected and labeled respirators are, of course, brought to the unit, released with that COC. During the disinfection, we make sure to label. Of course, there's a vaporized hydrogen peroxide disinfection in process, and we have a site supervisor on site for the duration. We'll recirculate the air throughout the unit during the VHP to make sure that every mask on every shelf is sufficiently exposed, and we have biological indicators placed throughout the entire unit, along with chemical indicators for a real-time result. And we also monitor the VHP ppm in real time. Following very defined exposure periods, 30 minutes of dwell after the generation and 2.5 hours of exposure even after that, then we'll begin venting until it gets back down to the 1 ppm OSHA limit in order to enter the unit. Following that, we also have a 300-minute minimum aeration period at the 1 ppm or low result. This is based on guidance of residue on the masks and how long any VHP residue may be present. In our experience, we have not found that even about 30 minutes later, any of the masks have residue, but we follow the 300-minute guidance. Our current EUA allows us to repeat this for up to 20 cycles per mask. We don't have any immediate plans to do so. We hope that we don't have to, but that is currently what the EUA will allow us to do. Each healthcare facility, by that QR code tracking system, we're able to report per mask, per ID, how many times that mask has been disinfected. The maximum we're at this point is, and that is TSS's disinfection solution.
In the meantime, I have a question. Does anyone know why the EAU is only for healthcare?
I can take a stab at it.
Great.
Here at UTMB, and I know PIs don't ever want to hear this, right? But, the research part of this is optional, right? So patients are going to keep coming and patients will come. And so patient care during this pandemic was not optional. Now, we did actually just what Megan also noted in her presentation is we moved as much as we could to the BSL-4 to try to conserve that PPE that we knew we were going to need for an increase in non-human primate studies at ABSL-3, or moving our PIs to reusable reusable respirators like the Halo Clean Space Unit, half-face respirators, PAPRs. But even as you know, getting those was still, a huge feat. So I don't know the real answer, but that is how we really did our risk assessment here.
What's the most creative thing you've done or used as far as PPE shortages or anything like that, whether it's during this pandemic or that earthquakes in Galveston, or if TSS has gotten odd calls to decontaminate other things that are short? I'm just curious.
I don't know if others have had the pleasure of receiving some random companies that decided to start making PAPRs during the pandemic. Has anyone had experience with that? We've received, we're very close to a lot of chemical industry here in Houston. And so Dow decided that they were going to make what they called a PAPR. And they were very excited, and they donated all of these units to UTMB for us to use. And when we ended up getting a hold of them, it was essentially, as we joked, we did everything that we were told as a small child not to do. They were a plastic bag that you put over your head with a drawstring, with a hose connected at the back and a blower. So everything about it just felt so wrong that we were like, put a plastic bag over our head with a string. Now, I would also like to remind you that UTMB has a maximum security prison hospital, which a lot of our COVID patients were in the maximum security hospital. So they wanted to give these down units so that we could use them, yet we're sending these into an area potentially, right, where someone could grab on to, a cord maybe and like choke their, prison guard. And so that has been the most interesting thing that I have seen donated to our entity for use during this pandemic.
Well, I'm saying, what about when she took me to the autopsy room because they wanted to do autopsies of both COVID patients and not COVID patients at the same time because there were too many. They were having a backlog.
So, yeah, we did, of course, a lot of autopsies, and we have a medical examiner's office, too, and just like everywhere else, bodies start building up. And so they had to start reprocessing them very quickly, and this is our expertise, so Miguel wasn't prepared, so we took him to autopsy. Actually, what we were trying to do was assist them in trying to break up the room into smaller rooms, just like we would in containment, so that they could do COVID positive patients at the same time as doing a non-COVID positive patient, just because the backlog was so great.
What kind of feedback have you all gotten? So either from PIs who want to be able to reuse PPE, or maybe healthcare workers who are a little hesitant or fearful of using reused PPE. Have any of you seen those success?
UTMB has done a really amazing job. If you actually go to UTMB website and go to our COVID-19 dedicated webpage, they've done a really amazing job at creating a lot of short videos. So we spent a lot of time in the beginning of this, and even we did a video explaining what reprocessing is, how we made sure it was safe, why we're doing it, and, to really help them understand that we're doing this for their safety, and we would never use something that we felt was unsafe for them. And so there's actually a bunch of really great short videos on just interviewing random departments at UTMB, why we're doing what we're doing. Researchers, of course, have been really good at sharing. We did a lot of PPE inventories across the board, who would be willing to share with other people, and really trying to accommodate that. Part of what did help is everything for a period of time at UTMB was you could only perform COVID-19 research. If you were not doing that, you were not doing research at all. So that did help us slow down a little bit. And all of that had to be on PAPRs, so we were not really utilizing N95s at that time. But I think the research community here has been very supportive in us trying to assist and help them.
I have seen more issues in Latin America, and it has to do mostly, I think, because of lack of trust in the government and the institution, that the healthcare staff do not trust them, and they think that they wanted to give them reused material because they didn't want to buy any material when they cannot really, you can find any material. So we have seen a lot of campaigns, and that's why one of the slides were in Spanish, because I've been doing some webinars and presentations. We presented our study in multiple countries in Latin America to try to say, yeah, this is something that you can do, because what is the option? Have something recycled or nothing?
Great. Well, I want to thank all of you for your participation in this, and if anyone has more questions, we can definitely send them your way via email.